It's my pleasure to introduce our next speaker, Dr. Bobby Tay, who has extensive experience in cervical spine, and he's going to share with us his experiences in cervical arthroplasty.
Thanks, Lee. Well, it's wonderful to be here, and thank you to Lee and Lionel and Kyle for putting this together. It's always a beautiful place to give a talk. My patients are not pediatric patients. My patients don't do the butterfly. They don't do gymnastics. They sit down and drink wine, and they maybe go biking and fall off and break their neck once in a while. So therefore, to go over this talk, it's really about cervical disc replacement. This has been going around for a long time. I was part of the PRODISC clinical trial back in 2000. I visited Europe when Rudy Bernoulli put in the first one-level cervical TDR, the PRODISC in Germany, and Terry Marnet put in the first two-level in the world in France. So this is kind of a long journey, and as you can tell, this is we have well over 20 plus years experience in putting in disc replacements in cervical spine. And a lot of the things I'm going to tell you you probably know already, because you've all probably have used cervical disc replacements for select patients within your practice. The important thing is that we learn things from the patients, not who just do well. It's actually the patients that fail these surgeries, and people who have recurrent pain, have failures of the implant. And each one of them, although painful, they teach us something about how to choose the next patient more wisely, more carefully. So let's start off with a case. This patient is a 52-year-old anesthesiologist. He wanted to play golf, couldn't play golf because his left tricep was bothering him, and he couldn't work very well because every time he tried to intubate a patient, his hands would go numb. He dealt with this for a long time because he's a doctor. He doesn't want to go get anything taken care of. He had to lose time from work. But after several years of this, he decided that it was not getting better. It was actually slowly getting worse. And his distribution of discomfort was in the C6 and C7 distribution in the left arm. Over time, it did get a little bit worse and started going to a C8 distribution, which I couldn't figure out. But he wanted something done, and he actually did not wish to have, he wanted to spare as much motion as possible. This is X-ray. AP and lateral X-ray shows multi-level cervical spondylosis, disc degeneration. This is his pain pattern, a little bit in the upper shoulder area, which could be around C5, some of the triceps, C7, and he did report some C6 symptoms as well. His cervical spine MRI shows developmental cervical stenosis, multi-level disc degeneration, worse at 4, 5, 5, 6, and 6, 7, as typical as you would see in most patients who have degenerative disease in his age group. And he's got both a mix of developmental stenosis with some moderate cervical stenosis at multiple levels and foraminal stenosis. So this is a person with really potentially 3-level symptomatic disease and cervical stenosis without myelopathy, mainly radiculopathy, but some weakness in C7. And it's a patient that if you fuse 3 levels in his neck, he's going to probably look at a 25% chance of coming back for another surgery to fix the pseudoarthrosis at one more level. If you did a 3-level disc replacement on this patient, it's a little bit dicey because it's not approved for more than 2 levels in the US. But I've done those before, but not been exactly as happy with them as with the 1 and 2 level operations. And this is, again, 5, 6, right? 6, 7. And this is what I ended up doing for him. I did a hybrid surgery. I did fusion at the level that he was weak, really decompressed him well, and did disc replacements above that at the intervening levels, which had some stenosis, but more foraminal stenosis, which was more pain generating rather than weakness generating. And he did great. About 3 weeks later, he followed with me, and he was already playing golf, and he was very happy. He was back to work. This is another patient that I actually followed, but I actually did do his surgery, a 40-year-old with myelopathy. You've probably seen this because I presented this one many a time because I've followed him for the last probably 15, 16 years since he had his index operation. He had a 4-level disc replacement done in Germany by Rudy Bertinoli because he was an airline pilot. He had multi-level cervical stenosis, myelopathic. He went over to Germany, got off the airplane, and became frankly myelopathic, went to the hospital and ended up getting 4 levels done. Post-op, he had so much more discomfort, neck pain, tingling in his hands. He had that for basically a year, and then he finally got better. And as you can imagine, doing that many levels probably stretched his cord, and he had myelopathy and some problems with the spinal cord already, and this exacerbated symptoms, and luckily he got better. But this was back in mid-2000s, and now he's 223. This is 2023 x-rays, and he still moves, and I clear him every year to still be a pilot. So it's a very unique situations for both patients. Both were treated, had similar problems, treated slightly differently, both with reasonably good outcomes, but can you imagine what the hospital course was, how different for each one of those. And if we had a patient that we did this to and had severe worsening of myelopathy right after surgery, we wouldn't have the luxury of keeping them and watching them for a year. We'd probably end up doing another surgery, take those implants out. So there's multiple disc replacements out there on the market, and I'm sure everybody has had some experience with one or more of these. And as time goes by, the technology is going to get better. These implants are becoming more MRI compatible. They're becoming more compliant, mimicking the disc better, potentially at a cost. And with new technology comes new problems, and you have to be wary of accepting or using new technology too early, as they may, in the intermediate term, have issues that you didn't know about. So we can talk about that. The inclusion criteria for these replacements are, patients with radiculopathy, myelopathy, cervical stenosis, foraminal stenosis, but the exclusion criteria are clearly the important things. You have to look at the patient's bone quality. They can't be osteoporotic. Their facets have to be good. They can't have too much collapse. You look on the AP x-rays or CT scans to make sure their uncus is not fused, because if their uncus is fused, you're not going to be able to mobilize a segment. If they're too collapsed, especially around C3-4, you're not going to have an implant that's going to fit in well, and you're going to overstuff that implant, and the patient might have discomfort afterwards. Obviously, patients with tumors and infections are a no-go. But otherwise, most patients can potentially be, most patients with radiculopathy can potentially benefit from this. These are the one-level arm studies compared to ACDF, and since everybody likes to use this thing called equipoise, I'm going to use it too. This is showing equipoise, right? It's clinical equipoise. There's no real difference between the fusions and the disc replacement patients, upwards of into about 7 years now. But and everybody improves, and that tells you how good ACDFs are, and that tells you that disc replacements for one-level surgery actually work pretty well in the correct patient. Now, when you go into 2 levels, that's when things start to separate out a little bit. And for patients who have 2-level disease and 2-level disc replacements, they tend to seemingly do better. And a couple of studies from both the MOBI-C and the Prestige LP demonstrate that, with 2-level arms being significantly better over time than the 2-level fusions. And these are the studies that show that, both with fairly large numbers of patients over time. And at around 2 years or so, they tend to separate in their outcomes, and between 2 and 4 years. So the 2-level arms tend to start to do better. And they definitely have less reoperations over time, over a 10-year period. And this again shows, if you see that, they start to separate between 2 and 4 years. So let's see, what else is good? So what are the pearls? So what is a pearl? A pearl is caused by something that causes an irritation, right? And complications are the irritation. And we we learn from each one of those and try to be better. And in my experience, complications that I've seen run into multiple categories, but some things we can't do anything about, which are inherent to the implant itself, which is heterotopic ossification. But other things that we can potentially do something about, such as inadequate decompression, subsidence, aseptic loosening, inadequate end plate prep, and the creation of segmental hypermobility. Most of these things that we can do about are typically because you're doing it in a patient that is marginal, because we really want, or they really want, to have a motion-sparing option. So we go the extra mile and we run up short. And heterotopic ossification occurs in all these implants over time. And they can occur anteriorly or posteriorly or both. And it can be a cause of secondary surgery, but as you can see, it also is dependent upon what type of implant that you use. Some implants have a predilection for anterior heterotopic ossification formation, and others have a predilection for posterior heterotopic ossification, which is not so good because it causes potentially recurrent stenosis. Eventually what happens is that this HO leads to loss of motion over time. And at around, probably around the 5 to 7 year point, the implants start to lose motion. And as time goes by, as you can imagine, the motion gets distributed or made up by the adjacent levels. So adjacent level disease, although it may be modified by the use of cervical disc replacement, it probably is not eliminated. This, again, you can see that in this study, the inferior adjacent and superior adjacent levels over time do increase their motion as the implant itself, which are the lines in the middle, decrease their motion over the 10-year period. Inadequate decompression. Now, this is a guy who came in to see me initially because he had this fusion, he wanted disc replacement. Can you imagine? I said, you should get a laminoplasty or something like that. I can't do this. So he goes, where did they go? They go to Germany, right? This guy went to France, actually. He went to France and he got these M6 discs put in there. The problem with the M6 disc was that he ended up having, they kind of, according to him, they kind of just did the surgery real fast, and he came out like still having his myelopathic symptoms and radicular symptoms. So he came back to me with radiculopathy, and I said, oh, well, you should do a laminoplasty. He goes, no, I'm going to go back to Germany. So he goes back to Germany, has another person take out the M6 discs and put in the Prodisc Nova. And the Prodisc Nova is it's not even available here yet, but it was put in, this guy was done probably 15 years ago too. So that was, they have options there that we don't have, but he ended up actually doing quite well neurologically. But over time, these things started to get HO and then they froze up and he lost range of motion. And you can see the implants don't really move very much after about 10 years. And especially on lateral bending. And you can tell when things are starting to stiffen up because the lateral bending goes away. They can't turn their heads from side to side. That's when you know that there's some fusion problems going on with their implants. So this gentleman had a great operation done by an outside physician. 2-level simplified discs for right-sided radiculopathy. Woke up with left-sided radiculopathy. And the issue here is that he still had some left-sided foraminal stenosis that probably wasn't addressed at the time of the index operation. Because with a fusion, you can get away with something like that. You can just decompress the side that he has a radiculopathy, because the implant and the fusion keeps that stable and you get indirect distraction. But with a motion-sparing device, you actually have to go and clean out both sides, and because it won't tolerate something like this. So he ended up getting a posterior two-level endoscopic foraminotomy and did quite well after that. But then again, should we do that instead of, should we tell the patient that and not take out too much bone and have him still remain a good candidate for an implant that won't subside? Or do we try to go after something like that and he'll subside and then you'll have to do a fusion? So in a way, this was probably a better course for him if they felt that left-sided level, that left-sided foramen was, they had to resect too much bone, it would potentially impact the stability of the implant. Shell kyphosis. Shell kyphosis is when you take out too much from the back, and it leads to an implant that loses flexion. It's limited in flexion. You get more extension, which could put more facet loads on and give you a little bit more neck pain, but does not tend to cause any issues with radiculopathy. Now, this is a person, a physician, who ended up being sent to me after she had this done. And she wanted, again, a motion-sparing operation. She had significant spondylosis. The surgeons did a corpectomy and topped it off with a disc replacement. But if you look back at her index X-rays, it's pretty clear that those spaces are very collapsed. And it's gonna, you look at that and it's high level, it's gonna be really hard to get an implant in without removing a lot of bone. And this probably was done. A lot of bone was removed. The patient's disc implant subsided a bit, and it went into have some instability and shell kyphosis. And she had to be revised to a fusion, after which she did quite well. The next thing is technical, and this patient had post-op neck pain because the implant was actually not healed in. As you can see from his intraoperative fluoroscopic images, there's a gap between the implant and the host bone interface on the cephalad shell. And the reason why that is that when you go off, and this is what happens, the implant shifts around a little bit. He doesn't seem to have any significant foraminal stenosis. And on the CT, it kind of looks okay, but on the X-ray, it's clearly there's a gap there. So when you go in and on the intraoperative fluoroscopic image, you can still see that gap. And when you go in and take the shell out, you see that underneath that little hook, that little anterior osteophyte, which we typically take off when we do an ACDF, there's a bunch of cartilage there that was left remaining, because that cartilage you can't see. So it's not so easy to take it all out. So you have to really, when you go in there and put an implant in, you have to really go and get underneath the areas that you can't see and remove the cartilage so you get good bony surface for the implant to heal onto. Otherwise, it'll become loose. So he was fused after that. So let's talk about osteolysis. The disc is not a synovial joint, so therefore osteolysis cannot occur. Well, that's a bunch of bull, right? You can see osteolysis occurs. And in this particular implant, which is quite interesting, the M6, there was a report in Australia, and the report showed that out of 56 patients that were implanted with the M6 disc, about 18 of them, or 34%, ended up with osteolysis at about 3 or 4 years post-op. And the osteolysis was thought to be due to the fact that the polyethylene bellows that contained the central core broke down because it was not tested in the torsional motions that normal people end up putting in. On the standard ASTM testing, flexion, extension, lateral bending, it didn't really cause any wear, but in vivo, when patients were moving their necks, it caused strain on that particular weave and caused the weave to break down, causing particular debris and osteolysis. And those patients had to be revised. Many of them were asymptomatic. So if you put in M6 implants, you may want to keep an eye on your patients because they may not come back until the osteolysis is very severe. Same thing here. And then finally, segmental hypermobility. Now, these are patients that typically are hybrid patients or patients with a clipophile that you want to save a level on. And sometimes it works, sometimes it doesn't. It makes sense to try to spare some of that motion, but as you can see, sometimes the implants fail. And we don't know, I have no idea what to recommend for that other than to be wary and tell the patient that that can be a case. And if they develop hypermobility, they'll develop neurologic symptoms from it. And then end up with the same operation as they should have had probably in the first place. So it is an extraction. So extracting these implants are actually fairly easy. Okay, so conclusions. Outcomes from single levels are clinically equivalent to our gold standard with this one level ACDF. For two-level disc replacement patients, they seemingly tend to do better in the intermediate and longer term because of less reoperations. And greater than 3 levels, we don't really have a lot of data. Some anecdotal evidence, some patients that do well, and it's clearly others that don't. And we know that at least for the 2-level arms, they can slow down ASD, but it's not the kind of the total solution, right? Because adjacent segment disease will occur as the implants start to lose motion over time. So you have to pick your patients very wisely and be good, make sure that they know all the things that they should in terms of potential adverse events for these new technologies and let them make the decision. So thank you. Perfect.
Just a quick.
Dr. Lyer.
Enjoyed your talk, Bobby. We see some advertisements from a surgeon in Los Angeles who's been undoing fusions and converting them to total disc replacements. Is there any data on that, rationale for that makes sense, or do you have any experience with those patients?
I don't do them that way, clearly, because there's a couple of things that occur when you try to take down a fusion is the host bone interface becomes very weak. Usually the area becomes, I guess, osteopenic from the fact that it doesn't move. And sometimes the facets in the back are already, because of the mobilization, they're already auto-fused. So I guess you can do it in the patient that doesn't have facet autofusion, but it's like, I think it's just advertising and versus overall good sense. We used to have a guy who did it in our local area who would take them down, but I think he's lost his privileges in multiple hospitals.
Yeah, I would think that. I would think they'd be falling apart.
Yeah, doesn't make a lot of sense. Yes, sir.
Oh, yeah. It's great talk. I'm Yun from Seoul. So I have a quite long experience in TDR, cervical TDR, especially for soft disc herniation. But recently, many papers are touching the degenerative spondylotic myelopathy by TDR surgery. So in my perspective, still the fusion is the best option for CSM. What is your opinion about the TDR, role of TDR in CSM?
Yeah.
Bony spur and the multiple facet degeneration. A lot of things are involved in the
Yeah,
CSM.
I think that's a great question. So, it's like there are a subset of patients who have developmental stenosis that still have a significant amount of good facet joints, right? They have their cartilage is still good, and they would be typically treated by us with a laminoplasty, right? That's what my go-to operation for those patients would be. But some patients have neck pain and they want to have something done that's motion sparing. So those particular patients that are mainly kind of disc bulge, developmental stenosis patients might be reasonable candidates for a disc replacement at multiple levels. If you have a patient with frank spondylosis, like some of those patients we saw here, with disc collapse, stiffness, when you look at their CT scans, they're usually autofused in their uncus. You're not going to get very much motion out of them unless you do a Dan-Ruve bilateral radical uncinectomy, right? And you can do that, but then like, why do that when you actually have a good operation to treat the problem already? That's what I think. So for severe spondylosis, if you're going to end up resecting a lot of bony material, and you can tell that when you look at the CT, you have a huge posterior osteophyte that needs to be removed, I typically would do a fusion. On the patients who have have like moderate spinal stenosis, I would consider doing a disc replacement on them, as long as their facets are okay.
Okay, thank you.
All right. Bobby, I have a question for you. So great talk. I think HO is definitely a real problem. It seems like to me, looking at the literature, the reported rate is a bit different amongst different regions in the world. We have, some surgeon from China here actually, but, reported rate in mainland China is like up to 70%. So, they were doing TDRs 10, 15 years ago, but, basically, essentially, they all stopped doing it, right? Yeah. Japan just a few years ago started doing it after looking at the 10-year data because they have a nationalized healthcare. But what's your opinion? Have you seen difference in like different ethnicities of patients that you treated, and also what do you have a protocol to reduce that? Do you use NSAIDs or Celebrex, or what's your sort of routine?
Yeah, so originally when we did the ProDisc C studies, we didn't see a lot of posterior HO from that particular implant. And where we saw the HO were in the Bryan discs. And when we originally trained on Bryan disc replacements, it was very, the technique was very involved, with a lot of milling, a lot of bony debris that was generated from the milling devices to allow the bone to be contoured to allow placement of the implant. So we had thought that originally that all that bony dust that ended up in the canal created a nidus for HO formation, and people started to irrigate the canal out quite a bit after they milled, and the milling process had changed for Bryan, and I think we saw less HO formation there. But clearly, internationally, there are people that there are clearly races that are pro calcium formation or pro HO formation, like we have higher preponderance of OPLL in the Asian population. So there's probably genetic differences in how we create bone and how we lay bone down. And that's a very, very good point.
I'd like to add one comment on this topic. So actually, about 10 years ago, we published our HO data. It's around 80%. Is the most, the highest the incidence of HO in the literature. So one of the reasons is the technical issue that you mentioned. And second one is the ethnic difference. So especially East Asian population, Korean, there's a high incidence, prevalence of OPLL as well. So there's a risk of some higher risk of the HO in our ethnic population. Yeah.
And as we know, when you have OPLL, the presence of motion can cause the OPLL to grow faster. And when you do disc implants, when you initially put the implant in, that disc actually moves more than the segment than it was initially moving. So you've increased the motion initially, and that motion starts to deteriorate or diminish over time, over the ensuing probably couple of years. But during that period of hypermobility, transient hypermobility, it could have set off a higher potential for HO formation if you're predisposed genetically.
Thanks, Bobby,
Thank
for a
you.
great talk.